So there we go. If you want to say anything to my father and Jan and wish him a happy retirement, or just keep up with them, they're on Facebook constantly. As most of you probably know, my dad's constantly posting. So is Jan. They are right now in Key West, just celebrating the start of their celebration of their official retirement. So with that being said, we have some new faces, but we're hoping to provide the same great service. The person that has primarily replaced Jan is Karen Gibson. Karen Gibson is an inside sales coordinator. She joins us with 25 years of experience. She actually had Jan's role in my office or my sister company, Teleacoustics in Florida. So, we're not losing a lot. We still have some experience, and she's really, really here to help and serve us and serve you. So if there's anything she can do, she'd be glad. Just pick up the phone, give her a call, or shoot her an email. She'd be glad to help. Replacing my aunt, who is a service coordinator, is a gentleman by the name of Chris Constantino. He is new to the industry, but I've known him for years, so he's familiar with it. And he's done a bang up job. He actually started in the midst of COVID and was the only person that would go to the office and do shipping, receiving, and those day-to-day things to keep the business open. While Frank, the rest of the techs, myself, we're out on the road serving our customers best we can. These two additions, I think, are going to help us through this transition and into the future. We also just hired another a service admin as well to help with Frank, and her name is Stephanie Overton. I don't have a headshot, but she has started. So I think, I hope, I know we'll be able to serve you and just as well, if not better, than we have in the past. And the last Alex Stanley, that's me. So I'm here to serve. I do have 25 years experience. I'm here for you guys. So if you need anything, I'll easy to get a hold of. Of course, if you have my cell phone number, if not, you can call the office, and somebody will just redirect you to me directly if you need me, or shoot me an email. Okay? I'm going to be here for another 30 years at least. So I look forward to working with everybody moving forward. That's it. That's my MedAcoustics update. So without further ado, I would like to introduce our guest speaker for this evening. Is that okay?
Yes, please. Yes.
Oh, okay. All right. So without further delay, I'd like to introduce our guest speaker, Monica Patterson, is a pediatric audiologist working with the new Georgia Mobile Audiology Program within the Georgia Department of Education. Very exciting, very innovative thing they're doing here. I expect you all to learn a lot with this presentation. She brings over 19 years of audiology experience. Most notably, she has been an educational audiologist for a school district of over 56,000 students. Her child-focused personal approach has been successful in fostering positive outcomes for students and families in need of audiological services. Monica is a member of the Educational Audiology Association and the American Speech Language and Hearing Association. So join me and welcome Monica. Yay.
Okay, there we are. Can everyone hear me now?
Yay, yes, we can.
Hey, okay. So I'm going to try this again. Let's see if I can share my screen. All right, and we're going to go back to the presentation view. Come on, there we are. Yay. Okay, sorry about that, guys. Well, let me just start by saying thank you so much for spending time with me tonight. We're going to explore the need for pediatric audiology and the complexities of early intervention. As Greg mentioned, my background is primarily with educational audiology, but as long as I've been practicing, I've always dealt with kids. So pediatrics is my love at heart. And, you know, our program, Georgia Mobile Audiology, has been around for a little over a year. But within that year, we've traveled all over the state and met many, many new people. Although our program is geared towards the rural areas of the state, I've learned so much in just a little over a year about early intervention, particularly here in the state of Georgia. So with that, let's start with our learning objectives. First, we want to talk about understanding early intervention services available in Georgia for families of deaf and hard of hearing children. We want to explore the relationship between audiologists and early intervention services, particularly the impact that audiologists have on early intervention services. And last but not least, I'm just going to explore the weak points of our deaf hard of hearing ecosystem here in our state and how audiologists can play a pivotal role in hopefully repairing some of those weak points. All right, so whenever myself or my team members give a presentation, we always like to give the audience, no matter who they are, just some general information that you should know. First, the prevalence of hearing loss in children birth to age 5 is roughly 3 in 1,000, but it actually increases to 9 in 1,000 for school-age kiddos. Children who are identified and receive deaf and hard of hearing services earlier have better outcomes in language literacy and academics. And these last 2 points deal with more of the financial aspect. Children who receive early identification and intervention have an estimated lifetime educational cost savings of a little over $115,000 per child over the course of their educational career. And last but not least, just unidentified, let's see if I can see. Unidentified and unmanaged hearing loss results in a loss of household income of up to $30,000 per year. So sometimes when we're talking about children and pediatric audiology, a lot of times the financial burden isn't talked about, but it's very, very important. So let's review the importance of early diagnosis for children with hearing loss. I know I'm preaching to the choir, but we're still going to review some things that I think are really important. I borrowed this slide from Marion Downs Hearing Center because I really like the top where it talks about critical milestones with the goal of age-appropriate language. So when we discuss early intervention, the overarching goal is language acquisition. So no matter if a child who's deaf and hard of hearing chooses language of a spoken language modality versus a visual language modality, it all boils down to language acquisition. So with that being said, the goal here in the state of Georgia are what we call 136, where a infant is screened by 1 month of age. If that child fails a screening, they then receive diagnostic testing by the age of 3 months. And once that diagnosis is made, early intervention happens by the age of 6 months. These are the goals here in our state. So you may be asking the question, why? Why do we have these goals? Well, let's start from the beginning. Newborn hearing screening, as I mentioned, the goal is to have an infant screened by the age of 1 month. Well, first, it's a statewide mandate. It's usually a fairly quick test, as we all know. It's usually a distortion product or transient OAE. Anyone who's trained can complete the screening. It cannot tell us if the child has hearing loss. It just tells us if that child needs additional testing. It's completed typically at birth in the birthing hospital prior to discharge. And if an infant refers the first screening, they will have a second screening either at the hospital or an outpatient. As I mentioned, we travel quite a bit with my program, and I've found that when you get outside of Metro Atlanta, most initial screens and rescreens are done in the hospital because it's typically the only facility that's offering the screening. And even if a family discharges from the hospital, typically they go back to the birthing hospital to have the second screening. All right, so moving on, let's talk a little bit about the second goal. That's diagnostic auditory brainstem response testing. Here, this occurs after an infant has failed 2 screenings. That's usually, that's the way it should go. Although in our travels, we're finding that there are some hospitals that aren't really sticking with the 2 screening protocol. But, you know, after the second screening, then a diagnostic test should be happening. As we know, diagnostic ABR typically takes about 2 hours to complete. It's always completed by a licensed audiologist. Although not all of us do ABR testing, it's a fairly specialized test. We do require that infants to be sleeping soundly. And we also want our patients to be a little less than 4 months developmentally in order to complete the testing without sedation. All right, so as we're breaking down these goals, let's talk about next step after the hearing loss has been diagnosed and identified. Typically, the audiologist who has diagnosed the infant will refer them to see an otolaryngologist to obtain medical clearance for hearing aid use, also to obtain additional tests to determine the cause of the loss. There may be other issues going on with the child. We also want the family to locate an audiologist who's able to fit their child with hearing aids or amplification. And typically around this time after the diagnosis is made, the family should be contacted by one of Georgia's public early intervention resources. And we're gonna break those down tonight. But just to get you familiar, there's Georgia Pines, Children's First, Georgia Hands and Voices, etc. And some families, they go ahead and choose to enroll their child into speech therapy. All right. Just continuing that journey, the next step would be that child wear amplification devices, usually all waking hours, and the child begins their journey with their fitting audiologist, where they're visiting every 1 to 6 months, depending on their age, for various services. The family should have ongoing parent education support through early intervention. And I think I added that sometimes a child will receive regular speech language therapy. All right, so let's talk about why these milestones are so important. As I mentioned in the beginning, language acquisition is what's most important. No matter what type of modality the family chooses to communicate in, whether that's spoken language or a visual language. Christine, this is a study conducted by Christine Yoshinaga-Itano, who's a professor at the University of Colorado. And her work centers around language development of early and late identified children with hearing loss. And within the study, if you'll take a look, she found that children with typical cognitive abilities, those who had early intervention happening before the age of 6 months, were able to, let's see, sorry, I'm losing my place. They were able to acquire language like their typical hearing peers. So within the study, she found that it really didn't matter their socioeconomic status, the degree of hearing impairment, the gender, minority status. All these children in the study, of course, received early intervention within 2 months of identification. So why is newborn hearing screening and follow-up testing so important? If a child has undiagnosed hearing loss, it can impact the child's speech and language development, their ability to learn, and ultimately their academic success. A diagnosis provides the child with numerous services, resources otherwise that wouldn't be available. So, let's see. There we go. There's one update I do need to make, and it's important that we all understand, although Currently in Georgia, our milestones are focused towards the 136 model. The Journal of Early Hearing Detection and Intervention released a position statement in 2019. And I just pulled a couple, I feel free to look at their position statement. I encourage all of you to read it. But two things that stood out to me was that they're moving from not just 136, but they're eventually moving to 123, meaning screening, follow-up screening by 1 month of age, diagnostic ABR testing by age of 2 months, and early intervention services happening by the age of 3 months. The other piece that the position statement, the other piece of the position statement that I felt was really important is that they are encouraging audiologists to be able to follow up a referred ABARE, automated auditory brainstem response screening, with DPOAE screening only if there are no other risk factors in the infant's medical history. So a few changes are coming. I just felt like it was important that I shared this update with you guys because eventually we'd like to see this update happen here in our state. All right, so I'm not sure if you guys are familiar, I hope so, with one of my favorite movies, Willy Wonka and the Chocolate Factory. For those who aren't familiar, the young man in the movie wanted to have access to Willy Wonka's chocolate factory with goodies, treats, and all of that. So, but there was one thing the young man needed in order to get into Willy Wonka's chocolate factory. And do you guys remember? They needed the golden ticket. So as we're looking at this movie, we can compare it to the state of Georgia, where you can't have access to the goodies of resources and early intervention without the golden ticket of a diagnosis. All right, so changing gears, we're going to talk about the early intervention services that are available here in our state. And I just wanted to provide you guys with a roadmap. If you take a look at the map towards the top, you'll see where I have listed your state and your district early hearing detection intervention programs. Towards the bottom, you see Georgia Hands and Voices and Georgia Pines. But in the middle, you'll notice that the roadmap, all of these programs are connected to SENS, which is an acronym that stands for State Electronic Notifiable Disease Surveillance System, SENS. So you may be asking, what is SENS? SENS is a database that's used to store and analyze data relating to EDDI's 136 benchmarks for screening, diagnosis, and early intervention services. The SENS database facilitates follow-up for infants and children who need further evaluation, promotes use of standardized protocols throughout the state. And this last point is really juicy. SENS provides access to information regarding hearing status to providers. All right, so when you log into the SENS database system, this is if you're familiar with it, you do know you have to have a login. When you go inside of the system, you log underneath the audiology portal. And this is where an audiologist would put the results of testing for a child who's anywhere from from birth to age 5. If you notice on the screen, this just shows you just a snapshot of what that SENS system looks like as you're entering that critical information. All follow-up tests for infants who do not pass the initial hearing screening should be entered here. All newly identified permanent childhood hearing loss for children up to 5 years of age should be entered here as well. And remember, this is a useful portal if you encounter a patient who's under the age of 5 and you just want to know what's the history, or you're not getting a really good case history from the parent in terms of when was a child tested, were they screened in the hospital, what were the results of that screening. You can go into the SENS system, place your patient's information inside the portal, and it will let you know the history of that patient. So when it comes to the SINS database portal, Dr. Brant Culpepper is the EDDI lead, and she is the person you would contact if you want to have a login, for example, or if you have any other questions about the SINS database system. And these are some frequently asked questions she shared with me about SINS. I'm not going to read through each one of these questions, but just two that stood out to me that I want to bring to light tonight is number one, what happens if new information entered in SINS does not match previous information? So for example, let's say an infant failed their first screening, they had a diagnostic test that reads as normal. Brant Culpepper at that point will be notified, and she will verify the results and follow up if necessary. Let's look at number 5. I work in a busy ENT practice. If a parent comes in with a 2-year-old and reports the child passed their newborn hearing screening, do I have to do anything in SINS? You always want to verify within SINS. So sometimes the parent may not realize that the infant had not passed in both ears. And you know, they may be reporting to you that they passed, but according to the SINS system, that's not necessarily the case. So when you define early intervention, I'm going to continue to harp on this. It's really all about language, whether it's spoken language or a visual language. Language acquisition is the goal. Okay, so we're still talking about SINS, but right now I want to put a spotlight on EDDI, or early hearing detection intervention. As I mentioned, Brant Culpepper is the lead EDDI, the EDDI lead, and she is an audiologist. But then there are also district EDDI coordinators. The important thing to remember about EDDI is that these coordinators are spread throughout the state, much like our health departments, where they have different regions that they cover. These EDDI coordinators are spread throughout the state, and they receive information from the SINS database system. And essentially, I'm gonna skip ahead a little bit. Essentially, they take that information that audiologists input into the system, and that's how they know what families to contact for early intervention. So just a breakdown about EDDI, they're under the umbrella of Health Services and Health Resources and Services Administration. And it's a program, the programs that enable states, territories, families, and providers to develop complete and coordinated systems of care. So one may ask, what exactly is an EDDI coordinator's role? What do they do? This information I gleaned directly from an EDDI coordinator, Patricia Rodriguez, who works in Gainesville. And she broke down pretty much the job of an EDDI coordinator is to maintain detailed knowledge of state mandate guidelines and policies. They can perform comprehensive tracking, follow up for the program. They contact parents. They maintain accurate client records and SINS. They maintain accurate reports, and they do a lot of data collection, which they pull together, submitting it to Dr. Culpepper, who then generates reports that's giving information about the state of newborn hearing screening here in Georgia. All right, towards the bottom, they do follow loss to follow-up protocol with referrals. So for families who may have had a initial newborn hearing screening but never returned for the follow-up screening, they're able to track those families down using that SINS data information. All right, so some frequently asked questions for EDDI that a lot of audiologists have. I'm not going to read through each question, but two that really stood out to me are, number one, are EDDI coordinators able to complete the newborn hearing screening themselves? And in Paulina, I keep calling her Patricia. Paulina's case, she does do rescreens. So as with our health departments, how each department works a little differently to a degree, EDDI coordinators operate a little differently as well. There are some facilities that have testing equipment where they're able to do the rescreen. And then we have other facilities throughout the state where they don't have that equipment, but they're able to help families get to an appointment with a provider who can provide that second screening. EDI coordinators do receive training to perform infant hearing screenings, but I do have to say they are limited. They're only able to screen infants who were born full term with no other medical conditions. And I think I highlighted number 3. I have had patients no show for numerous hearing screening appointments. Could the EDI coordinator assist? Yes. I think it's important for our audience to know that EDI coordinators really work hard to track down families. And as a matter of fact, Paulina shared that there's a minimum of 12 good faith attempts made to follow up or to find that family, to educate them about the need to have that second screening for their baby. And I'm sorry, I'm going to add one thing. Number 5. If a child needs a loaner hearing aid through the Georgia Loaner Bank, do we contact you or do we submit the application directly to them? She graciously answered that audiologists can submit applications to the district EDI coordinator, and the coordinator will let you know once it is approved. So the Georgia Loaner Hearing Aid Bank goes through the EDI program. I have to admit, before I joined Georgia Mobile Audiology, I wasn't very familiar with the Georgia Loaner Bank, but the Loaner Bank is a great resource for families who need assistance with finding a device for their child. And number 6 kind of gets more in depth with that. Is there payment authorization for hearing aid fitting and amplification? For birth to 36 months, EDI is the payer of last resort and will pay the Medicaid rate. For Georgia Loaner Bank, audiologists are reimbursed a total of $150 for the ear mold and fitting fee. So yes, if a family is desperate need for amplification, sometimes when we discuss cochlear implantation, how some families, they go through the trial of wearing hearing aids first before implantation. They will go through the Georgia Loaner Bank sometimes because it's a great resource for families who are needing amplification pretty quickly. All right, so any questions so far about EDI? And we can just keep on rolling. The next early intervention program I'm going to discuss really are 2, Children's First and Babies Can't Wait. So you may be asking, what is Children's First? Children's First, and before I get in depth, I have to admit a lot of these programs overlap in description. What I need for you guys to do is just to focus on the age, the requirement age for these programs. Because some do the same thing, but you'll notice that the age requirements are different. There may be a few differences in the service provision for these early intervention programs, but just pay attention to the age requirements, I would say. So Children's First collaborates with families, healthcare providers, schools, and other agencies to identify children birth to age 5 who may be at risk for poor health outcomes. Children's First is the single point of entry for all DPH child health programs and services for children birth to age 5. All referrals made to DPH child health programs include Babies Can't Wait, Children's Medical Services, and EDI. All right, so I'm sorry. Let's go back to the roadmap so I don't get you guys confused. Remember, the district EDI coordinator receives the information from SINS that a child has been diagnosed with loss. Depending on the diagnosis and the needs of that child, that coordinator and Children's First, working hand in hand, will then refer different early intervention programs to that family. So if you look underneath the umbrella of your district EDI coordinator, there's Children's First, Babies Can't Wait, children's medical services. So let's move on to Babies Can't Wait. Babies Can't Wait is Georgia's early intervention program that offers a variety of coordinated services for infants and toddlers with special needs from birth to 3 years of age, and their families. Okay, so that's birth to 3. They provide early identification and screening of children with developmental delays and chronic health conditions. They really are, part of their goal is to improve the developmental potential of infants and toddlers birth to age 3. Okay, and they do support family members. So of course, the natural question is, what's the difference between Children's First and Babies Can't Wait? Without reading everything word for word, Children's First acts as a single point of entry for referrals to all children with health programs under DPH. So remember, I was telling you guys about paying attention to that age requirement. Babies Can't Wait serves children 0 to 3, and Children's First serves children 0 to 5. How does a child qualify for Children's First and Babies Can't Wait? Is there a minimum hearing loss requirement, income requirement? Reading into that description, and again, I got this information directly from a Children's First coordinator. There is, with Babies Can't Wait, they pay for evaluations for children age birth to 3. Of course, that is on a sliding scale, and they're evaluating the child for developmental delay. There is no income requirement for either program, but Babies Can't Wait families are given they're charged a participation fee depending on the amount of income they bring in, and as well as their insurance coverage. All right, so let's see, let's move on to children's medical services. Okay, so children's medical services is a little different from Babies Can't Wait and Children's First, because in order to qualify or in order to be in the program, it's for children who are age birth to age 21. And as you can see on the screen, who's eligible are Georgia residents, those who are under the age of 21. They do have to meet a financial eligibility. If you go on to Children's Medical Services website, it lists the different chronic health conditions that they serve. I just pulled out some vision and hearing disorders because of what we do. The way to enroll into that program, you simply go on the website. They do have a Children's Medical Services coordinator, and that coordinator will assist the family. They also help with medical services and durable medical equipment not paid for by Medicaid. And they also give access to specialty health clinics. When I was an educational audiologist in the schools, oftentimes I would use Children's Medical Services for families who did not have insurance coverage, or if they were not legal citizens and they needed care with, let's say, an otolaryngologist. Children's Medical Services was very helpful in leading families in the right direction. Even with medical devices, Children's Medical Services, again, they serve children with chronic health conditions. They are a last payer of resort. Okay, and here are some helpful resources and links for Children's First, Babies Can't Wait, and Children's Medical Services. All right, are there any questions about those programs before we move on?
I don't see anything yet. You're doing a great job. So I say we keep on going.
All right, we'll keep going. Okay, so, oops, wrong way. Let's go back to that roadmap. And now we're going to talk about Georgia Pines. And Georgia Pines, PINE stands for Parent Infant Network for Educational Services. So the natural question is, what is Georgia Pines? It is an early intervention program that serves infants and toddlers age birth to 3 who have hearing and vision loss. Georgia Pines, I have to put in a plug, is I believe the only early intervention program here in the state that's geared specifically towards hearing and vision loss. So their goal is to provide quality curriculum-based in-home instruction to the child and family so that the impact of sensory loss can be reduced. Language development is a huge focus of the program, and the earlier intervention can be provided, the better. Birth to 3 is a crucial age for language development, which affects brain development. Some important points audiologists need to know about Georgia Pines. The curriculum that they're using with the families was developed by Utah University Sky High Institute. Georgia Pines, they provide in-home visits, working with the family, supporting them with strategies and information. So the important thing about Georgia Pines, they work with the family dealing with language development, whether that language is visual or if that language is spoken orally. Georgia Pines have deaf mentors and parent advisors. Also, Georgia Pines houses early hearing orientation specialists. So, I'm sorry, I'm gonna go back a little bit. Within Georgia Pines, or shortly after diagnosis, the audiologist places the diagnosis, the information into SINS. Again, that triggers early intervention services. So that district EDI coordinator, Children's First, receives that information, and they actually reach out to the family to schedule an appointment with an EHOS representative, early hearing orientation specialist. That person goes to the home or conferences with the family to provide information regarding their child's hearing loss, to prepare the family to receive information from early intervention programs. They typically try to reach out to the family within 7 days of diagnosis, if they can get in touch with the family. And so oftentimes families after a diagnosis, they may receive several calls from different early intervention programs, again, because SINS has actually triggered that call, or they've triggered those services to happen for that family. All right, so we're gonna move on to Georgia Hands and Voices. All right, and under the umbrella of Georgia Hands and Voices, there's also Guide by Your Side and Astra, okay? So the purpose of Georgia Hands and Voices, it's a parent-driven nonprofit organization. They're dedicated to supporting families of children who are deaf and hard of hearing. They practice a non-biased approach around communication. It's a sincere belief that parents can make the best communication choice for their child, if they receive the necessary supports and information. Astra is a bit different. The Astra program offers advocacy and support at no charge, for children age 3 who are entering school up until graduation. Guide by Your Side, they also give advocacy to a family through specially trained parents of children who are deaf or hard of hearing. These parents work as guides, directly directing the family and helping them as they cope with the diagnosis of hearing loss. So the differences between Georgia Hands and Voices, Astra, Guide by Your Side, Astra and Guide by Your Side are underneath the umbrella of Georgia Hands and Voices. Astra is more of a program that supports advocacy for parents as they're dealing with the school system, dealing with IEPs or 504s. Guide by Your Side helps families throughout the entire process, dealing with the diagnosis that their child has and helping them in any way that they can. All right, so some important facts about Georgia Hands and Voices. Obviously, how can you refer a family for Georgia Hands and Voices? You can simply go on their website. Georgia Hands and Voices are actually tied to Georgia Pines. Just so you know, Deshonda Washington is the executive director of Georgia Hands and Voices, and she's a great person to reach out to if you have specific questions about Hands and Voices, Guide by Your Side, or the Astra program. Number 4, are there any events parents can attend to meet other parents? They're really, really good at providing social networking for families. I know we're living in the days of a pandemic, but they've adjusted. They've gone virtual with their social events. And so I encourage you, if you have a family that may be in need of extra support, Georgia Hands and Voices is a wonderful resource. All right, and here's some helpful resource links for that. So going back to Willy Wonka and the Chocolate Factory, these are the services, early intervention services that require a DHH diagnosis. And we talked about the majority on the screen. Georgia Pines, Children's First, Guide by Your Side, all of these services, you must have that diagnosis. But what happens when there is no diagnosis, or that diagnosis isn't placed into the SENS system? Eddie will assist families in getting testing. We have Grady Hospital's Access to Language program, and of course, Georgia Mobile Audiology program. But I have to be honest, all 3 of these, what we're going to do is just to help the family get the diagnosis so that early intervention services can happen. All right, so switching gears a little bit, let's talk about the relationship between early intervention and audiologists. Audiologists play a vital role in connecting families to early intervention, specifically via SENS, that SENS portal that I've been talking about all night. Audiologists can refer families to local early intervention programs. We can educate families on the need for early intervention, and just simply communicating with your local district coordinators, whether it be Eddie, Children's Medical Services, Babies Can't Wait. And obviously, don't forget that peer-to-peer connections work, like with Georgia Hands and Voices. All right, so these are just some suggestions for audiologists that I gleaned from early interventionists. Without reading through each one, the overarching theme is communicate. They really want audiologists to communicate more with those district coordinators. Entering data in a timely fashion provides results to EDI coordinators, making referrals to early intervention programs, sharing records when requested in a timely manner. All of these things, all of these suggestions center around communication. Okay, so how many of you guys remember the MTV program, The Real World? Right now, we're going to talk a little bit about 136 in the real world. What does Georgia's data look like? And I borrowed this. Let's see if my dash is up. Oh, there we go. Sorry. I borrowed this from the Language and Literacy Outcomes for Children Who Are Deaf and Hard of Hearing from the OCGA 30-1-5. I'm not sure if many of you know about the language and literacy law that has passed here in our state. And just taking a quick snapshot, some of this data is from 2017. The newest report is on its way, pandemic pending. But I do feel like it's important to look at, even though some of this data is from 2017, 2018, it does give us a good idea of where we are as a state when it comes to our 136 benchmarks. All right, so this first dash, it says 96%, and basically that is the percentage of newborn hearing screening that happened by 1 month of age in 2017. 96%, that's great. So you may be asking, why is this number so high? Well, first of all, newborn hearing screening is a statewide mandate. The law requires hearing screening to be conducted on no fewer than 95% of all newborn infants in hospitals, and requires hospitals and physicians to educate parents of the importance of screening and follow-up care. So essentially, newborn hearing screening gets built into the hospital system. And newborn hearing screening does not necessarily have to be completed by an audiologist. It can be a trained person, and it's a very short time commitment. So let's take a look at the next dash. This says 32%. And this represents, of the babies born in 2017, this is the percentage of those who failed their first and second newborn hearing screening, and they were able to receive a full diagnostic ABR. So that number dropped from 96% to only 32% of infants who failed the newborn and second screening. But why is this number so low? All right, let's look at the steps behind newborn hearing screening. So the newborn hearing screening technician, as I said, is just a trained person who must explain to a family why their child may have failed their screening. And they have to educate the family about the importance of a diagnostic ABR. The family themselves must locate an audiologist who is able to complete that ABR test. Of course, when we get into the testing, we need the patient to be sleeping. Remember, it's 2 hours. Then the audiologist or technician must enter the diagnostic results into the SENS system. Remember, so when we talk about potential weak points, you got a couple things happening. For one, sometimes that newborn hearing screening technician doesn't quite do a thorough job of educating that family. Sometimes, I mean, it's a natural tendency to not want to give bad news. So sometimes those technicians may tell a family, well, baby may have failed the screening, they may have had fluid, not really driving home the point that a diagnostic test must be done. The family must locate an audiologist to complete the ABR. There may be issues surrounding transportation. There may be other issues dealing with insurance. Then, of course, there's the test itself. An ABR, again, is 2 hours and the infant must be sleeping. And sometimes that doesn't always happen during the first evaluation. It may take more than one appointment to get it done. And obviously, the audiologist must enter information into SENS, and sometimes that isn't always done in a timely manner. All right, so take a look at this map. This map is scary to me, but it lists the hearing diagnostic centers here in our state. So if you take a look at our map, the areas in blue represent the places where a child can receive a diagnostic ABR. So with that being said, you see the darker blue shaded area represents Metro Atlanta. But as you move away from the city, this map gets lighter and lighter. And, just looking at the southeast and southwest corners of the state, there are lots of counties where there is no diagnostic center available or local. So a lot of these families are having to travel far to have their child undergo diagnostic testing. So of course, a natural question is the lack of access to diagnostic ABRs. And there are a couple reasons. Clinics and hospitals cannot bill if they cannot test. So as I mentioned, sometimes it takes more than one visit to get a complete ABR. Equipment is expensive. Sometimes, going back a little bit, the lighter shaded areas, as I mentioned, there may be one center that's performing ABR tests. And even then, that center, they may not be performing the test regularly. So sometimes those audiologists aren't fully comfortable with their test results, and they may still send the family to Atlanta to have a second opinion or a second diagnostic ABR. And obviously health insurance can sometimes become an arbitrary obstacle. As you know, families are waiting for Medicaid approval, and or it may not even be Medicaid, it may be just other insurance that it just takes time to get paid for. All right, so remember Willy Wonka and the Chocolate Factory? We need that golden ticket, that diagnosis, in order to trigger early intervention services to happen. So when we look at this third dash, 35%, that represents the percentage of children who received a diagnostic ABR that shows hearing loss. Of that population, only 35% were actually enrolled in early intervention by the age of 6 months. So why is that percentage so low? All right, and let's go back to those steps that we discussed. And I highlighted 2 areas that I think are pertinent for our audience. And that goes back to families locating an audiologist who's able to fit their child with hearing aids. Is there an audiologist close by who will take their insurance, who actually deals with pediatrics? And the state only knows about the diagnosis if the audiologist entered the data into SINS. So, if they didn't enter the data, there's no way that these programs know that the child exists and that they're in need of these services. Okay, so what are some ways that providers can help prevent loss to follow-up? All right, we need to recognize that the system makes it hard for families, unfortunately. Utilize resources available to you to assist families. So reaching out to the social worker, these these early intervention coordinators, communicating with your patient's providers, getting a release of information so that it's more of a team approach, taking a village, as they say. You also want to research resources that may help pay for families' transportation, appointments, etc. Encourage families to apply for Medicaid for those who don't have any insurance coverage. And, some practices are able to look into the option of offering free screening days. I know that in the Savannah area, there are some audiologists who, they'll just take 1 day a week to offer, or one day a week, one morning a week, to offer free rescreens for families. So, of course, what resources exist? What can we use to help barriers to follow up? I'm going to go into my program later on, but the Jason Cunningham Foundation, Children's Medical Services, Lions Lighthouse, and Georgia Hearing Aid Loaner Bank. The Jason Cunningham Foundation will cover the costs of barriers to audiological care. So, for example, transportation issues. Sometimes they'll cover, small devices, batteries, etc. It's just a matter of going onto the Jason Cunningham Foundation's website, contacting them, and someone from the Jason Cunningham Foundation will reach out to you, especially if you have a family that's really needing a helping hand just to make it to their diagnostic appointment, or just trying to find services in their area, audiological services in their area. Right now, my program, Georgia Mobile Audiology, on our website, we're partnering with Jason Cunningham Foundation. And throughout the pandemic, we've actually been giving free batteries to families, free hearing aid, cochlear implant batteries. It's just a matter of going onto our website and applying. There's no income requirement, there's no citizenship requirement, and that's been going. Jason Cunningham Foundation has been supplying that, and we're still going. The pandemic is still raging, so they've graciously been offering that. Children's Medical Services, I mentioned before, they will pay for certain medical devices, and even for visits for specialty clinics, such as an otolaryngologist, for example, for a child who has a chronic medical condition. And, permanent hearing loss is a chronic medical condition. All right, Lions Lighthouse. Although Lions Lighthouse is going through some changes right now, they are available to help not only adults, but pediatric patients. And of course, I mentioned the Georgia Hearing Aid Loaner Bank earlier in the presentation. They're affiliated with the EDDI program. All right, I just added this picture because I love a baby. Okay, so changing gears a little bit, I'm going to talk about my program, Georgia Mobile Audiology. Essentially, our program's been around for a little over a year. We're funded by the Georgia legislature, as well as the Georgia Department of Education. The goals of our program are for families to have access to audiological services in a timely manner. We want the overall rate of children lost to follow-up to go down. We do help school-age children receive timely identification, ongoing care and management. And we do help families with navigate through the system, our DHH ecosystem. This is a picture of our vehicle. We call her Sunny. And she is a full clinic on wheels. Forgive the water bottle in the picture, but this is our sound booth. We're fully equipped with anything needed for audiologic care. This is our staff. I am the acting program manager. My partner, Melanie Carter Morris, is an audiologist in her background. She formerly was a clinical audiologist at Children's Healthcare of Atlanta. And she really, really loves infant ABR testing. I do too, but it's her passion. And then we have Stormy Combs, a family education and engagement specialist. Her background, she was a certified teacher of the deaf for over 15 years, and she resides in Valdosta, Georgia, in that southwest corner of the state. She's also a Georgia Pines intervention specialist, and she specializes in working with children who use ASL as well as spoken language. All right, so naturally, we're always asked, what services do we provide? As I mentioned, we are doing infant ABR testing. We also do behavioral testing, hearing aid management, family education, community outreach, and care coordination. We have really been working hard on teleaudiology. We are doing infant ABR tests through teleaudiology. We've been partnering with Fulton County Health Department, and we're very proud of it. It's been running really smoothly. We also have been doing some teleaudiology with the Southwest Valdosta area. We're really trying to target areas of the state that are in desperate need. As I showed you tonight, that map of the Georgia Diagnostic Centers, it's pretty sad. And so a lot of those families coming from other parts outside of the city are having a really hard time making appointments to Atlanta to get diagnostic testing done. So we're hoping to help with some of that. We're also providing educational audiology services to school districts. We are free to families who want to make an appointment. When it comes to school systems, that's a different conversation. We're housed, again, underneath the Department of Education, and we do offer contracts to school districts who need our services, whether it be screening or comprehensive testing. This is where we've gone thus far, and I really need to update this map because we we have been everywhere. Our program is geared towards rural areas of the state, but we visited all over, visiting different EDDI coordinators, Babies Can't Wait, early intervention coordinators, just to get a feel for what's needed in a particular area. So, we did a roadshow tour just to introduce ourselves, but now that we're getting our feet wet, we're finding that we're really not needed in Augusta, Savannah. Those places are covered in terms of audiologists. We are focusing towards that southwest corner of the state, the southeast area, where there really are little to no audiologists practicing. All right, these are our partners. Children's Healthcare of Atlanta, Georgia State, DPH, etc. And that's pretty much, what we're doing right now. As things change, particularly with teleaudiology, we've been adapting because we are just one van for the entire state. So we try to reach as many people, as many families as possible. And we're hoping through teleaudiology, we're able to spread even wider. But any questions about our program or anything that I presented tonight? I just wanted to open the floor for questions.
Sure. This is Vicki, and I do have a question. We're finding at Kaiser, just across the country, that people are starting to, on the second screen of baby, also do a tympanogram. And we've been debating that because, the second screen is supposed to remain a screen. The concern is if you find fluid, the parents might not be as apt to come back because I think it's fluid and not hearing loss, and there's kids out there with mixed loss. Have you had any conversations about that, here in Georgia, whether that's a practice that we're starting to do?
Great question. Haven't heard a lot of feedback specifically about tympanogram, but I do know as we have been performing rescreens, we automatically do tympanograms on our patients. So haven't heard much about, in terms of making those changes. I know Brant Culpepper is a great resource to answer that question. And, I probably would pose it to her because she, again, is the lead Eddie coordinator, I suppose. And we're hoping to partner with Eddie more to do more infant testing. But no, not specifically. I haven't heard much feedback about using tympanometry in the second screen.
Okay, thanks. Oh, another question. Real quick. Could I have availability of some of your slides? Because I would like to give some of the services, like the slide that had the voices and hands and the, contact information.
Oh, yes, yes. I think I can share my slides with Krista, who can certainly get it out to everyone. I want you to have my slides because it just gives some up-to-date information about the early intervention programs in our state and just the best way to get in contact with them. When I was doing the frequently asked questions, each one of those slides, they were answered directly by those early intervention specialists. So they want us to contact them. So yes, I'll make sure that my slides are available for everyone.
Thank you.
We'll be happy to put that on the website and email it out to the GAA members. This is Lacey Sharp.
Sure. Let's see, any other questions for me? I felt like I went so fast.
It was all really good information. I mean, it was really well put together. Thank you.
Thank you. I hope so. It's been a journey with Georgia Mobile Audiology. Just to share, we had our maiden voyage with the truck happen about a little over a month ago, and we traveled down to Valdosta, and I don't know if you guys are familiar with Lenox, Georgia. And I have to say, my parents are from South Georgia, so I'm familiar with South Georgia to an extent. They're from Brunswick. But I had never heard of Lenox, Georgia. And when I say one stoplight town, it was literally one stoplight town. But everywhere we went with our mobile truck, everyone's so welcoming and just so grateful that they have someone that's close by to actually do some of the testing. So it's, things have been going really, really well with the program, even though we're in the middle of a pandemic. And it's just really, really exciting just to be able to travel, to meet people in person, to actually, you have literally a clinic on wheels. So it's really, really exciting, and stay tuned. I would love to give everyone an update of how it's going. I think we will be spreading our wings. We're in the process of trying to acquire an audiology assistant right now. In my dreams, I'm hoping that we'll have more than one truck for the entire state, because we're finding that even in some areas that we didn't think would need us, they need us. So, audiology is growing, and particularly with teleaudiology, I think that's really going to open a world, a whole new world with providing diagnostic ABRs. So I'm really, really excited about that.
Well, this was really great, Monica. Thank you so much.
Thank you. Listen, I think I went really quickly. I'm early.
That's okay. I don't think anybody's going to argue with that.
Okay.
It's totally fine. But
On a
thank you so
Thursday
much.
night, right? Thank you so much for having me. I'll definitely share my slides. Please, please, please reach out to me if you think of any questions, or maybe you need some guidance with early intervention programs. I know a lot of the programs, the descriptions overlap so much. It can get confusing, but I'm here to help in any way. Oh, I need to give a plug. Our program has started the Georgia Pediatric Audiology Network, which is a social network for pediatric audiologists throughout the state. Please, please, please check it out. It's similar to a Facebook page, but not really. It's more of a social sharing of information and ideas. We do provide need-to-know information on that. And sorry, second plug, there's going to be a pediatric audiology symposium. I think the first one last year we had to change a bit because of the pandemic, but apparently this summer we will have a virtual pediatric audiology symposium where we're partnering with the University of Georgia Speech and Hearing Clinic. And just some great information about pediatric audiology, networking, etc. So be on the lookout for that. And I would love to send an email blast about that as soon as I get more information about marketing. But yes, things are growing. So we have some professional development tools. Check out our website. All that information is on there.
Can I ask one question before you go, Monica? This is Lacey Sharp. I was just wondering if you would have any ideas of creating any sort of list, or if you already have one, for people who are looking to get sedated ABRs, or ABRs on adults who may need to be sedated instead of just for children. I know when I worked at Emory, I had several patients who were very difficult to test, and we had a really hard time trying to find resources to do that kind of a test. I had one specific special allowance at CHOA to do one of those kinds of tests, but it was very difficult to come by. I was just curious if you might have any ideas about how to get resources on that.
Let me work on that. I have to speak with my colleague Melanie Carter Morris about that, because she has immersed herself in all things ABR.
Okay.
So I'm gonna get with her to answer that. But that has come up before, and I think that we meaning my program, should go ahead and maybe present some of those resources on our website. So give me some time to work on that, Lacey. And if you don't mind, send me your information through the chat.
Okay.
Then I'll see what I can uncover. The other great thing about that Georgia Pediatric Audiology Network is that, and even about my program, we are again, we are under the umbrella of Georgia Department of Education. So we do have access to a lot of information about resources across the state. So, you know, questions like that are welcomed. And yes, you're right, Lacey. It's become more and more of an issue across the state.
Okay. Ryan Hinklow was saying that Melanie has a list and he believes she posted it on the Georgia Audiology on My Mind Facebook page. So I'll have to-
Yay. Okay, thank you. Thank you, Ryan. I'll ask her about that tomorrow and see if we can get that list.
Okay, great.
And I'll do you one better. Let's see if I can get the list to Laura as she's, you know, distributing my slides.
That'd be awesome. Thank you.
Mm-hmm. No problemo. Okay.
Well, thank you so much.
Thank you, everyone. Listen, stay safe, take care, and I hopefully will see all of you really soon.
Yeah, everybody have a great night.
Yes, thank you.